This video continues Chapter 15 of OEC6 by looking at cardiovascular emergencies and specifically the management of patients with cardiovascular emergencies. So we'll look at treatment of different cardiovascular emergencies, including the administration of medications such as aspirin and nitroglycerin. Now, in a cardiovascular emergency, time is of the essence. The more time that passes, the greater the extent of a myocardial infarction, and the more likely it will proceed to sudden cardiac arrest. So transport with ALS should happen immediately, and in the meantime, call for oxygen, especially if the patient becomes cyanotic. As with all assessment, our initial care focuses on the ABCDs. If the patient has difficulty breathing, make sure the airway is open and assist their breathing efforts with high-flow oxygen or perhaps even a bag valve mask. If you see the patient being pale, cool, and clammy, administer oxygen immediately. Now, in the case of cardiac arrest, we need to correct that life threat by beginning CPR and calling for an AED as soon as possible, along with requesting ALS. Oxygen can be provided, but recognize the primary problem if a patient is pulseless and not breathing is a lack of perfusion, and we need to immediately begin CPR. CPR flips ABCDs into CAB. We assess that circulation first of all by checking for a pulse. In an unresponsive patient, this is using the carotid artery. If there is no pulse, begin chest compressions and open the airway and begin BLS or CPR measures immediately. Now, specific to CPR, we consider 5 lengths in the chain of survival. The first is the immediate activation of EMS. The second is immediate CPR, focusing on high-quality chest compressions, followed by rapid application of the AED, transfer to advanced life support through EMS, and then in the hospital, we can look at some strategies for post-arrest care. Now, the first link in the chain of survival is recognizing signs and symptoms of sudden cardiac arrest. Any delay will decrease the patient's chances of survival. For OEC technicians, we follow the lead of the American Heart Association and their emergency cardiac care standards for CPR. Every OEC technician must demonstrate CPR skills annually to a CPR instructor, even if their current certification is for 2 years, an annual skills demonstration. Survival is very much impacted by a delay in application of CPR. We want to pump the remaining oxygenated blood from the heart to other vital organs, so we consider effective chest compressions. Push hard, push fast, and allow for full recoil of the chest to occur so that the chambers of the heart refill. Once begun, do not stop CPR until the patient's pulse returns or temporarily during the analysis step of the AED, which will announce it. Rescuers become too tired to continue, or you've transferred care of the patient to a healthcare provider of higher status. Sadly, a 5th option for stopping CPR is the patient is declared dead. Now, our third link in the chain of survival is rapid defibrillation. For ventricular fibrillation and ventricular tachycardia, application of the AED is essential. We can maintain circulation to vital organs through CPR, but to reestablish a spontaneous pulse in the patient, we need defibrillation. We'll do that with the AED converting VTAC or VFib to an effective heartbeat. How? By stopping the heart's electrical activity after it provides a shock and allowing the heart's internal pacemaker to reset. Survival is going to be greatly improved if this happens. After 10 minutes of no CPR, the heart is nearly completely non-responsive. So what CPR does is basically expand the time window during which application of the AED may be effective. We need to apply the AED quickly. If there are 2 rescuers on scene, One person can perform CPR with high quality compressions, right rate, right depth, and full recoil, while the second rescuer finds and applies the AED. Once the AED is turned on, listen to it and follow its prompts. Stop CPR only when it's ready to analyze and in case it's ready to apply a shock. The fourth link in the chain of survival is transfer to advanced EMS. Their advanced life support will allow them to provide life-saving medications to the patient. The fifth link in the chain is transfer to a critical care facility, and that definitive care at the hospital is important because of their ability to provide such things as clot-busting drugs or even move the patient to angioplasty, in which the blocked coronary artery is opened with a balloon, or even a cardiac stent, which opens the blocked coronary artery with a small wire mesh tube. In some cases, we can allow for repair of that coronary artery by bypassing it using a vein from the patient's leg, arm, or chest. Other possibilities for post-arrest care are a ventricular assist device that's essentially a mechanical pump that helps the failing heart that has poor muscle structure pump blood either to distal tissues from the aorta, exiting the left ventricle, or into the pulmonary arteries headed to the lungs from the right ventricle. It's not an artificial heart, but it assists the patient's own heart. Now, patients with a VAD need special care. They're not going to have their own pulse because rather than pumping in discrete rhythms, the artificial pump's flow is kind of continuous. So blood pressure is going to be hard to obtain, because there's no pulse pressure. Most of these patients will be on blood thinners such as Coumadin, and a pulse oximeter will not read accurately. The patient may also receive an AICD, which is a device that detects life-threatening arrhythmias and then supplies a shock to the heart to restore the normal heartbeat. If you have a patient with one of these devices, you may uncover that in a patient history by checking with a bystander, family, or friend, and then call 911. Now, routine CPR with an AED can be done, but it is possible that the device will be damaged in such an event. For cardiovascular patients not in cardiac arrest, just be aware that they may proceed to cardiac arrest at any time. So make sure that you have assistance, oxygen, AED, and call for ALS. Keep the patient calm to reduce any stress on the heart. Also, place them in a position of comfort, such as sitting up, because this may help breathing for some types of cardiovascular emergencies, such as congestive heart failure or pulmonary edema, or it may help for the patient with chest pain due to angina, allowing them to breathe more easily. If a patient has extremely low blood pressure, then we can place them in a supine position. Oxygen therapy is important because it will help maintain good perfusion. So administer it at 15 liters per minute with a non-rebreather mask. Check it with a pulse oximeter. If the patient will not tolerate a non-rebreather mask, administer the oxygen at 4 to 6 liters per minute using a nasal cannula. That's better than the 21% oxygen we get from the atmosphere. Now, some patients with angina may have nitroglycerin that's been prescribed. Only help them take this drug if it has been prescribed to them. Now, there are contraindications for this. Make sure that the drug is not expired and verify once again that it has been prescribed for them. Do not give it if the patient's blood pressure is less than 100 systolic. Why? Because nitroglycerin is a vasodilator. And so if you administer it to a patient with an already low blood pressure, you can cause a crash in their blood pressure that's very significant. Along with that, if they're taking an ED drug, which is also a vasodilator, don't give them nitroglycerin because then it's a vasodilator on top of a vasodilator and can be very dangerous. Once again, check their systolic BP to make sure it's greater than 100. Verify it belongs to the patient and is not expired. Put on your disposable gloves because nitroglycerin can be absorbed through the skin. Remove one tablet and instruct the patient to put it under their tongue so that it will dissolve and be absorbed sublingually. The patient may take a total of 3 doses at 5-minute intervals, but each time ensure that their systolic pressure is greater than 100 millimeters of mercury. Do not give more nitroglycerin if it is less than this. Recognize that they may have a burning sensation beneath the tongue and may get a headache as a result of this vasodilation from the nitroglycerin. Document the date, time, and dosage at which the drug was administered and keep rechecking vital signs. Aspirin is also useful for a patient having a heart attack, and the dosage is about 325 milligrams, which is 1 adult aspirin or 4 children's aspirins. 4 times 81 is 324. Because MIs are caused by a blood clot, and aspirin has the effect of preventing platelets from clotting, it's useful in this case. Do not give it to someone who is allergic to aspirin or sensitive to aspirin, and make sure that they're fully responsive and can swallow. To assist a patient, make sure that the patient is not allergic to aspirin, select the proper dosage, check the expiration date, and instruct the patient to chew the aspirin before swallowing it. This will allow it to be absorbed more effectively. Document the date, time, and the dosage, and monitor vital signs. Minimize the patient's physical exertion, which would increase the oxygen demand. Now, there are other high mortality conditions we may encounter, such as an aortic aneurysm or aortic dissection, pulmonary embolism, or pericardial tamponade. In this case, our treatment is limited. Treat for shock, provide oxygen, and load and go with the patient. Get them to ALS. For a cardiovascular patient not in cardiac arrest, remember, call immediately for assistance, oxygen, and the AED, and transport with ALS. Place the patient into a position of comfort, oftentimes sitting up, and again, be prepared to move to our CPR algorithm.